Lunch okay? Yeah. Weather okay? We're doing good. All right. So a couple quick things to provide updates on, and we'll be starting with our afternoon presentations. So first and foremost is a lot of folks have been coming up and thanking me for hosting the meeting for you all. And I just want to say that from me, from our PHN team, and from all the folks at Children's National, we're here to thank you for all the work that you are doing frontline primary care practices with kids and families. Thank you all so much for what you are doing every day. I also, not everyone knows who's running the hospital at Children's National. There's some changes of leadership or whatever, and just you got to meet our new CEO and president today, Michelle Riley Brown. She comes to us from Texas Children's, a little tiny community hospital, that covers half the state of Texas, and so she's really quite experienced, and we think is going to be a really great CEO. Just pointing out in terms of medical leadership, moving left to right, David Wessel is our Chief Medical Officer. David is triple or quadruple boarded in all these intensive care things, intensive care medicine, anesthesia, whatever. It's like Nathaniel Beers is now our Executive Vice President for Community and Population Health. So Nathaniel, you saw briefly this morning. Nathaniel is overseeing a lot of things that we are beginning, a lot of work that we are doing in the primary care and community space. A few of you have met Mark DeFazio. He's a pediatric neurologist, but he's also the Vice President working with our specialists around trying to upgrade and improve our ambulatory specialty services. So you'll hear from him. And a few of you may have met Dr. Kara Biddle. Kara is the division chief for general pediatrics. That's where primary care sits in the organization. She's also currently president of the medical staff. So that's, who's running the hospital. They got all sorts of other C-suite folks, but this is your medical leadership. And we're glad to get you connected if you want to chat. Hard to believe that this is 25 years. I do remember when Charlie Schulte and Tom Sullivan, pediatrician champions out of Northern Virginia, said, hey, let's do a meeting, and we were able to sort of put this together. And I'm not sure we envisioned that it would develop into quite the ongoing legacy, but we're thrilled to be here and sharing 25 years of really shared care and shared learning, not just from our specialists, but learning from each other. And it's all about your participation and support and the fact that you keep showing up. So I'm here to thank you. We've got a lot of partners in different collaborative care pilots. I'm not going to read all the names here, but if you look closely here, you will see the names of some of your friends and colleagues in different primary care practices around our region who have been early champions and working with our specialists on developing some pilot initiatives to improve access and what we do in our primary care setting and different collaborative care models. This is not a quick fix. It's going to take a while to sort of rebuild how we think and how we work together. That's part of what this conference is all about. It's not intended to be one and done. It's intended to be an ongoing starting point in just better communication and collaboration and working models between you all as primary care champions and pediatric specialists in our region. These meetings don't happen without people really doing a lot of heavy lifting. I get to come up here and crack jokes and MC, but our Pediatric Health Network has a crew who's been spending a lot of time making all this happen smoothly. So for Jody, Liz, Charlotte, and Sarah, thanks to them. This program is sponsored by our Pediatric Health Network, and we're here to sort of improve care, improve outcomes, improve how we are recognized for that work. We're now 6 years in, and we've built some robust data connectivity. We've established a quality improvement infrastructure and culture. We have added payer contracting expertise, and we are now successfully implementing value-based contracts for the practices who are members of our health network. How many folks are in our network? Well, actually close to 700 primary care pediatricians across our region are now actually connected, sharing data, contracting as a group, and measurably improving care and revenue. It doesn't happen without a team. We've got great physician leadership. You've met me and Ed Fox. You'll meet Claire this afternoon. We also have Lee Beers and Sandy Chung. Gee, how many organizations have not one but 2 past presidents of the American Academy of Pediatrics helping guide our leadership and offer perspective or whatever? So we've got great chops, and our professional team is just as robust in terms of managing our network and contracting and IT and business services. So thanks to them as well. We don't make all the decisions. There's a board of directors. What's important about seeing all these names is that more than half the names of our board of directors are your friends and colleagues in primary care practice who are part of our board and are basically saying, yep, focus on this. Nope, we don't care about that. So this is a group that really is championing what's important, not just for care for kids, but also what helps primary care pediatric practices be successful. We also learned that practices are as successful as their practice administrators or office managers. And we are fortunate to actually have built a robust group of practice administrators who get online, share things on a listserv, have regular meetings, and Rachel Baker-Smith and others have been sort of great champions in building that. That is available to folks as well. And just people don't go to the backs of journals to look for ads anymore. That's part of my gray beard. People go online and look for jobs. We host a job board. It's free. We get a lot of hits. So if you're recruiting for practitioners, folks may be out there looking at Indeed and other sorts of places, but our job board gets a lot of hits and connects many of our practices with folks who want to be pediatricians in your groups. And then lastly, some of this is funded. Almost everyone here is in some vaccine buying group. If you are not in a vaccine buying group, you definitely need to get in one because you shouldn't be paying full price. You should be leveraging that a bit. Our network runs a vaccine buying group. It's pretty competitive. One of the reasons we like it is we do get some money that comes back to us. What do we do with that money? Look around. This is what we do with our funding. We reinvest it in what works for you all. So we appreciate your support. Lastly, out at the booth and tables, there's a referring provider survey. Folks at our hospital, always want to know what you're thinking and doing. So we appreciate you filling that out. I was reminded to point out that today only, and today only, did I say today only? Today only, if you take the survey, you may be eligible to win either 2 tickets to the Tennis Open or 2 tickets to a Commanders home game. So take the survey, be honest, let folks know what you think. Maybe you win a ticket. And so we're teeing up the afternoon session. We also have a full agenda. It'll be very similar to the morning. There'll be a really quick break after lunch so we can clear the tables and get things all set up again. And another break around 3 o'clock. So we invite you to meet our exhibitor partners and those sorts of things. But we're going to run quick through to 4:30, try to end on time, so folks can just get a little bit ahead of the traffic out there. We do appreciate that many of you come long distances. There is no perfect location in the DMV. I wish there was. But we have folks coming from near Baltimore, folks from the Eastern Shore, folks from Northern Virginia. We really appreciate that you're all here and able to join us here. If you can find an alternate meeting site that really works for us, let me know. We're still always looking around, but we really appreciate your being here. Again, CME credit, it should be on the back of your agendas. And look at that, right on time. Claire, do you want to introduce Vahe? You can. It's okay. All right. So actually, Claire, just stand there. Stand up and wave. So Claire Bugard is also one of our other medical directors. She works with Ed Fox and me in terms of helping to look at our quality programs and our educational programs and other sorts of things. And it's all team effort. I get to stand up here and be Ken Jennings, but you know, it takes a team. Anyway, Dr. Badalyan, Vahe, I got it right. Okay, we actually go back a couple of years. So this green button advances the slides, and you're on.
Thank you very much.
Here is the best pediatricians in the DMV.
Hello, everybody. It's truly an honor to be presenting to such a distinguished group today. And thank you to the organizers for inviting me to give this talk. I am the medical director of the celiac program, so I'll just take this opportunity to do a quick plug for the celiac program. I always try to fit the patients in as quickly as possible, either if it's a suspected celiac patient or newly diagnosed celiac patient. So we can have them email us at celiac@childrensnational.org if the pediatricians and offices email us for expediting their appointments. We can do our best to fit them in, and I sometimes tell the pediatricians, just page me, have me page, and I'll figure something out. So just a quick plug. Let's see, let's move this forward. So today we'll be covering some basics of managing constipation in a busy pediatric office, and how we can educate the patients so that they accept the diagnosis and accept the treatment. We'll also talk a little bit about the protocols and when to refer. Disclosures, I don't have any disclosure. The only thing I will say is that I'm glad that my talk goes after lunch because we'll be talking about poop. So this is a busy slide, but when I meet with the patients, I illustrate to them that the colon is a very flexible and dynamic organ, and its major job is really to absorb the water. And a lot of colon's work is back and forth squeezing to compact the poop and also to squeeze all the water that it can. And another sort of small percent of the colon movements are these propagating movements that you can see in the middle, as illustrated by a colonic manometry. So those high pressure waves start from the right side and then go all the way to the rectosigmoid area to move the poop forward. On the right picture, you see the picture of the rectosigmoid area. And the key aspects here is that when the stool comes to the rectum, it stretches the receptors in the rectum, and that triggers the spinal reflexes that then initiate the defecation process. I recently read a big article, 25-page article about the physiology of human defecation. That was fascinating stuff. But it's really, really a complex process. And I think another key part here is the role of the internal sphincters. So internal anal sphincters are on quote unquote autopilot. They're responsible for the majority of the pressure inside the rectum, but they're on autopilot. They're dependent on the intrinsic system that works independently of the spinal cord. So if you have a patient that has spinal cord problem, their internal anal sphincters should still be functioning independently. And they should be able to relax those sphincters automatically when the rectum fills up. On the other hand, if you have somebody with a spinal cord, when you have somebody with Hirschsprung disease, those internal anal sphincters will be constantly under very, very high pressure. So they'll be not relaxing, and therefore the patient will have difficulties having the bowel movements. So lots of different factors play, and everything has to kind of be coordinated together. And I oftentimes tell my patients that this has to work like an orchestra at the nearby Strathmore Center, which is about a mile from here. So definitions for constipation, there are many, many different definitions. And one of the common ones is infrequent and painful bowel movements, sometimes with or without fecal incontinence, and with stool withholding behavior oftentimes. Intractable constipation means that the patient is not getting better despite optimal medical treatment for about 3 months. And fecal impaction is when the clinician feels hard, big, large masses of the stool on abdominal exam, or they do rectal exam and they feel the stool is completely occupying the dilated rectum, or on an X-ray. Fecal incontinence, we're not going to spend a lot of time on this, but this implies involuntary passage of the stool into the underwear in a toilet-trained or older child. And there's 2 types. One is retentive. That's the classic one when the stool is filling the rectum and stretching so badly that the child's sensation goes away and it starts to leak. The other one is non-retentive, when the rectum is not stretched, but the child may have psychological issues and they basically are incontinent because of that. And this is another phenomenon that occurs a lot in pediatric patients, dyssynergic defecation, because again, the defecation process requires careful orchestration of all these muscles and coordination. What happens in this case is that the child is bearing down, they're squeezing their abdominal muscles, they're going into the right position, but at the same time, instead of relaxing their external sphincters, they're actually squeezing the external sphincters. And external sphincters are controlled by the cortex, so the child has control over that. So their 2 groups of muscles are fighting against each other, and the child is having discomfort and pain and difficulties passing the stool. And this happens in really large proportion of the pediatric patients, especially the young patients. The criteria for diagnosing functional constipation are developed by a group of experts, and that meets from time to time in Rome. And this is the latest iteration of this Rome criteria, and they divide this into criteria for infants and toddlers, and then also criteria for older children. And if the child meets at least 2 of those criteria, then they can be diagnosed with functional constipation. These materials are available on Rome Foundation website, and we'll be also happy to share them with you. But basically, the common things would be less than 2 or less times stooling during the week, history of painful and hard stools. So if you have those 2 alone for over 1 month, then that's a pretty good way to diagnose somebody with constipation. The latest guidelines by the Pediatric Gastroenterology Society are dated from 2014, and new ones should be coming up either next year or the following year. These are developed in conjunction with the European colleagues. And the good news is that the vast majority of the patients with the constipation, they have functional constipation. Very small number of children will have organic cause. I put some statistics there on the right side. You can see 1 out of 5,000 will have Hirschsprung disease. So if I do mental math in my head, let's say in the greater DC area, we have about 6 million people, about 100,000 newborns each year. So roughly we have about 20 new children, 20 new babies that are born with Hirschsprung disease, as opposed to hundreds and thousands of children with constipation that you all see in your practices. In a busy practice, in a busy office, 15, 20 minutes are definitely not enough to get everything about the child's history of stooling and habits. So different guidelines and different articles try to focus on the key aspects of it so that it makes it easier. And this is just one of those versions. So I think the key two questions to ask is, when did the constipation start? What were the events surrounding the issue of constipation? And also learn a little bit about the bowel, specific bowel habits, and whether the child has any kind of urinary difficulties or incontinence. The Bristol stool chart, I routinely use this in my office. This helps us kind of get a little bit more concrete about what kind of stools is the child passing. This is a table about the red flags on history and physical, and every guideline, every article will have their own little version of this table. Some of them can be really long and can include things like botulism and all kinds of rare genetic syndromes. But some of the common ones are listed here. So if the baby or if the child had not passed the stool within the 48 hours after being born, that should raise a red flag. If the child is having distension, vomiting, not growing very well, those would be red flags. On the other hand, on the right side, I put some sobering statistics. While 99% of the healthy babies will pass their meconium within the 48 hours, so do also 30% of the newborns that have Hirschsprung disease. So although I ask my patients all the time, did they pass meconium within 24, 48 hours? When they say yes, part of me gets reassured, but then I always have to remind myself that maybe this child still has ultra short segment of Hirschsprung, and for that reason, a lot of children don't get diagnosed within the first few months or first few years when they have Hirschsprung disease. A lot of them can be diagnosed later. So that's always important to remember. And some aspects of the physical exam, again, the textbooks and the articles will go over lots and lots of details. And those are some of the obvious things to look for on the physical exam. But my key question is, how is the child's growth and nutrition? Is the child looking good nutritionally or not? Rectal exam, the guidelines say that the rectal exam is not necessary for routine screening. Again, when you apply the Rome criteria, you don't really have to do the rectal exam, but it can be useful if somebody wants to assess whether the child is impacted or if there's any kind of anal stenosis. Having said that, the perianal inspection is always going to be important to look for the spinal dimple and other problems. If somebody does a rectal exam and anal tone is very low, poor, then one can suspect spinal cord problem. And again, when we do the rectal exam on the babies, when we remove the finger and it's like the poop is flying out, then we get a little bit more concerned about Hirschsprung disease. And of course, sadly, sometimes the child can be extremely stressed out or nervous because they have been traumatized or abused. The X-rays are not routinely recommended to diagnose the functional constipation. This study was done analyzing 6 different research papers that covered 700 children, and they compared basically the children that were diagnosed using the Rome criteria with their X-rays, and they found that the correlation between the X-rays showing a lot of stool and the Rome criteria diagnosing functional constipation was not perfect. So having said that, sometimes we do get the X-rays. This paper done from Boston Children's, basically they took pediatric gastroenterologists and prospectively asked them, why did you order an X-ray on a child that you're seeing for constipation? And on the right side, you can see the most common answers. So most commonly, people do it to assess the stool burden, sometimes to decide whether the child needs a clean out, and in some cases, even just to demonstrate how much stool the child has on the X-ray to get a buy-in from the patient and the parent that they need to be treated. Having said that, in a different setting in the ER, sometimes X-ray can be tricky because a study from Canada showed that small, but still a significant number of children were misdiagnosed using the abdominal X-ray, misdiagnosed as constipation while they had appendicitis or intussusception or something else, and they had to come back within 7 days. So one has to take this a little bit with care. But of course, if you demonstrate something like this to the parent, oh my God, look at all this stool. So that kind of helps you target your treatment better and do the clean out and get a buy-in from the patients. The role of the labs is also a little bit, and the labs are also not essential, not necessary. This is a paper that shows results of a retrospective study from Canada, where about 7,000 children with constipation got all kinds of labs. And about a quarter of them got tested for celiac disease. Again, being the celiac program director, I'm happy that they got tested. And of those children that got tested, about 2% were diagnosed eventually with celiac disease. So 2% is a little bit more than the general population of 1%, but still this paper was arguing that perhaps testing, the cost benefit of the testing may not be supporting the testing. Hypothyroidism is another one that we always teach student and resident and the fellows, but you can see that of the 2,000 plus patients that got tested for hypothyroidism, only about 14 were picked up that way. So the guidelines recommend that if the child doesn't have any other symptoms, they don't have red flags, the role of the testing is very, very limited. And this paper calculated that on average, each child who got tested, they spent about $1,000. So altogether, it was like $4 million, something like that. Principles of management can be summarized with this diagram. Essentially, we will start on the left side with evaluation. We will sometimes do testing, but oftentimes we'll not do any testing. We'll just apply the Rome criteria and then go towards education, talking about the diet, behavioral modifications, and then move on to the treatment. And the treatment can be straight to the maintenance therapy, or sometimes we will have to do disimpaction before we go to the maintenance therapy. Then, of course, it's important to evaluate and follow up, and then decide whether the therapy has to be adjusted or if the child has to be referred. And then eventually, hopefully, some of the children will be at the point where we can start thinking about weaning them off from the therapy. There are lots of busy algorithms that have been developed. We're not going to be able to cover those, but this is the snapshot of the algorithms that have been developed by the Pediatric Health Network, collaboration of pediatricians with some of my colleagues in the GI department. The key aspects to discuss with the family about the therapy include demystifying constipation, giving them some information about why that happens, and the role of the non-medical therapies such as the diet and behavioral changes, but also focus on the laxatives and emphasizing that the laxatives are not dangerous. The laxatives should be used long-term rather than short-term, and that the concerns from some of the parents that children will develop dependence are not really real. I mean, it's real in their mind, but they're not really proven. In a way that we're shifting our language when we're talking about this with the patients, we say, well, if somebody has a diabetes and they're on insulin, does that make them dependent on insulin? If somebody has a hypertension, does that make them addicted to H2, beta blockers or ACE2 inhibitors? And same thing with the constipation. And importantly, we need to emphasize that stool withholding plays a big role, and dyssynergic defecation plays a big role. So we'll have to involve addressing those aspects as well when we're treating the child with constipation. A couple of things about the fibers. There's a fascinating paper about the physics of fiber, how the fibers work. And I recently learned that the liquid stool is 90% full of water, while the hard stool is 72%, or a little bit less than 70% full of water. So still, even the hardest stools have a lot of water in them. But yet that difference of 18 percentage points translates into 200-fold difference in viscosity of the stool. So fibers can be useful to keep the stools more full of water. There's two kinds of fibers, insoluble and soluble. So insoluble fibers, the way that they work is that the granules or the particles of the fiber, if they're the right size, they will irritate the colon and make the colon secrete mucus and water. And in fact, people have tried different studies when they use plastic particles, and that also achieved the same effect. It's just irritant of the colon. On the other hand, the soluble fibers, they will kind of swell up and form this gel type of substance that will suck in the water and keep the water there and make the stools more bulky and help the stool move forward. One thing is important to know that if the fiber is fermentable, it basically will lose its effectiveness. It will not do what we're using it for. So people should stay away from fermentable fibers. They should choose non-fermentable, soluble or insoluble fibers. The other caveat is that some of the fibers have small particles, and it's again, based on these physics experiments, they show that if it's a small fiber, a small particle fiber, actually, instead of making the constipation better, it actually can make it worse. So one has to be careful about the products that we choose. Psyllium husk, also called Metamucil, is the one that's a non-fermented soluble fiber. Citrusel is another one of those that potentially can be used. However, the guidelines emphasize that we don't really need to give children more, extra fiber on top of what the recommended numbers are. And typically, we use age of the child plus 5 grams a day. That's usual recommendation of dietary fiber for the children. Commonly used laxatives are listed in this table. Essentially, it's the polyethylene glycol, also known as Miralax, milk of magnesia, and lactulose. Those are the osmotic diuretics. Then we also use osmotic laxatives. We also use the stimulant laxatives, Senna or Bisacodil, and we use rectal preparations as well. The key thing, again, as I mentioned, is the disimpaction. We need to use high doses, either polyethylene glycol or polyethylene glycol plus a stimulant to disimpact the child. We will not going to be able to focus too much on the doses of this, but the PHN algorithms has all of this information available on the internet. For the long-term maintenance therapy, polyethylene glycol seems to be the best option. It's superior to lactulose and milk of magnesia, so that's always our first choice. The emphasis, again, that this needs to be used long-term rather than short-term. When it comes to weaning, one needs to remember and educate the patients that a significant proportion of the patients will not be able to be weaned off. About 50% can be weaned off within a year, but another 50% will have difficulties and will have frequent relapses. Polyethylene glycol is shown here. Basically, it's a polymeric molecule that uses hydrogen bonds to attach the water molecules, and that's how it does its job. And it's important to know that although all the guidelines will have dosing ranges, dosing is really individualized for every patient. So sometimes if one capsule doesn't work, go up to 2 capsules. And that doesn't work, go up to more, and so on and so forth. The only downside from Miralax or polyethylene glycol will be diarrhea. So we're going to skip these dosing tables because you will have that available. Couple of things about the safety of long-term use of polyethylene glycol. Some parent groups came up with some concerns many years ago, and FDA put out some statements about this. However, to date, we do not really have proven proof that polyethylene glycol causes any kind of neuropsychiatric problems among children. Nevertheless, if the patient says that I'm not comfortable with polyethylene glycol, although I explain it to them, I don't argue with them, I just switch them to something else. Lazy bowel syndrome with long-term use of laxatives also comes up from time to time, but again, the guidelines will tell you and the articles will tell you that this has not been described in the medical literature. This is more of a subjective feeling. And for that reason, there's all these papers that come out showing that PEG is safe, PEG is effective in young children and old children, and it's a game changer. It's been a game changer for the last 25 years. And for that reason, when the Rome committee meets again next time in Rome, I think they're going to change the ceiling of the Sistine Chapel and put Miralax picture there. So lactulose is another product. It's sort of a second choice. I like to use lactulose in younger children that don't drink a lot of liquids with their polyethylene glycol. It's a disaccharide, basically non-absorbable. It gets to the colon, it gets broken down by the bacteria, and then it starts to stimulate the peristalsis because the pH goes down, and also it creates the osmotic effect. The side effects will be cramping, bloating, and some gas. Magnesium or milk of magnesia. This in the GI community, we always we have a group that loves milk of magnesia and we have a group that hates milk of magnesia. So nevertheless, all the guidelines still show milk of magnesia as a very valid option. And I know a lot of pediatricians like to use this. In fact, some limited studies show that milk of magnesia may be actually better than lactulose, but the number of the patients was very low on this paper. We're going to skip through magnesium citrate because we're not really using this for long-term maintenance. The stimulant laxatives, basically stimulant laxatives will irritate and stimulate the nerve endings in the mucosa, and that will trigger more peristaltic action. The cramping and pain can be the common side effect. Common ones are listed here by Sacadil, also called Dulcolax. Our PHN algorithm does not include this as an option, but many GI groups will use this very, very heavily, and it's very effective. Senna is one that I typically use, although recently I started using more and more by Sacadil. It should be noted that Senna comes as a tablet, as a syrup, and as an X-Lax chocolate square. And anecdotally, the tablets, milligram for milligram, the tablets can be a little bit more potent, followed by the syrup, and then a little bit less potent is the X-Lax chocolate square. So people sometimes will use higher doses of chocolate square when they prescribe that. Senna long-term has been shown to be safe as well. The worst thing that happens in little children when they are on Senna is if their diapers don't get changed, they can get blisters, they can get diaper rash. In adults, very, very limited studies show that it can cause discoloration of the colon, melanosis coli. When you do the colonoscopy, you will see darker kind of surroundings. And then some limited studies shows that adenomas can be a little bit higher, but malignancies are not. Enemas definitely are very important when we have to do disimpaction. Sodium phosphate or fleet enema is our typical enema that we use. Mineral oil enemas are also good, but a lot of people say that it's kind of messy. It creates a lot of stains. So I like to use it when I do the rectal exam and I feel really, really hard stool, but oftentimes I will use the sodium phosphate. We're going to skip over the doses. And newer agents come on the market. One of them is has been approved in children above age 6. That's the linaclotide. But honestly, I think that if we use the osmotics and we use the stimulants in a correct way, in an individualized way, and long term, we probably are not even going to need any of these medications, especially that they're going to be expensive and insurance isn't going to really be too eager to approve those. We're going to skip on a biofeedback because this will require a whole another talk, but so far we don't really have a lot of evidence that biofeedback is going to be extremely important. However, the studies are still underway. Pelvic floor physical therapy is a nice one to use, especially when the child has dyssynergic defecation. Studies have shown that it can be, in addition to the osmotic laxatives, it can be increasing the effectiveness of the treatment of the functional constipation. And as I mentioned before, prognosis is, we should always remember that sometimes we will not be able to win the children from laxatives very quickly. And a sizable group still remains symptomatic even into the adolescence and adulthood. So when to refer to us, if there is red flags, if the child has refractory constipation despite escalating doses and good compliance, if the child needs lots of clean outs, if we're using stimulants for a long time, more than a year, then I think those would be certainly good reasons to refer to us. And of course, you're always welcome to refer, even if the child does not meet those criteria. But if you have some other concerns, you definitely are welcome to refer. So that's my last slide. Basically, educate, demystify, use long-term therapy, and don't shy away from stimulant laxatives as well. Thank you very much. Don't know if we have time for questions.
Yeah, we do.
Okay.
If there are questions, we have microphones here. Okay, the way our agenda is teed up, out of respect for people having lunch and this being a lunch session, we're going to have really a short mini break here, just about 10 minutes or so. Stretch, use the facilities. We're going to clear some tables, and then we're going to kick off the afternoon session in about 10 to 15 minutes. So Dr. Badalyan will be available to answer any questions outside. And we look forward to kicking off the afternoon session in a little bit. Thanks so much for being here. All right, folks, going to invite you back to your seats. Two quick updates before we kick off our afternoon session. One, a couple folks have noted that the room seems to be cooler than it was when we started this morning. So we have asked the hotel folks to crank up the temperature a little bit. I know our enthusiasm can raise the degrees a couple bit, but we're going to ask them to we're going to ask the building folks to sort of help out a little bit. The second thing is we were pointed out that a couple folks logging in into doing the CME at the GW website are getting an error message. We apologize for that. It's not on our end. We will get it fixed up. I don't know how soon, we don't control this. I don't know how soon they're going to get it fixed. It will be fixed. You will be able to get credit for a full day CME. I don't know if it'll be done this afternoon or in the next couple of days, but don't give up. Just keep logging back in, and we will also send out an email blast once we have it all tucked in so everyone knows what they can do. But you're generous enough to be here and sharing your time with us. We're committed in getting you the CME credit that you deserve. So we're going to make that happen. All right, we're going to kick off our afternoon session, and I'm going to invite Dr. Allison Mayhew up to the podium. And she's going to talk to us about adolescents. This green button, it's a little clipped here, but it's full screen up there. All right, just make sure you're talking to the mic. People can hear you.
Perfect.
All right.
Great. Oh,
And,
do I go back? Does
yeah,
it go
that
back?
way we go.
Okay, great.
We good?
Yeah.
Awesome. Thank you.
Hi, everyone. Thank you for joining me. My name is Allison Mayhew. I am the Director of Pediatric and Adolescent Gynecology at Children's. And today we're going to talk about dysmenorrhea in adolescents. I have nothing to disclose. And the goal of our talk today is mainly to review primary dysmenorrhea, including the initial workup and treatment strategies that you all can be utilizing in the primary care setting. But I also want to discuss some of the warning signs for secondary dysmenorrhea and some of the red flags for subspecialty referral. And at the end, I'm going to outline some of our long-term treatment strategies for some of the cases of secondary dysmenorrhea, particularly endometriosis, which is one of the most common causes of secondary dysmenorrhea in adolescents. So dysmenorrhea, as I tell my patients, this is the fancy way to say painful menstrual periods. It is the most common gynecologic complaint. And in the primary care setting, up to about 90% of menstruating teens will report some degree of dysmenorrhea. Dysmenorrhea can be mild, but it can also be severe, and it is the leading cause of recurrent short-term school and work absenteeism in adolescents and young adults who menstruate. We typically think about this happening during menstrual flow and being worse in the first 24 to 48 hours, and with resolution with the completion of menses. But I think it's important to remember that dysmenorrhea is not just pain. Yes, it's abdominal pain. It can radiate to the buttock, to the groin, and to the thigh, but it can also be described as back pain. Some of my patients report nausea, vomiting, a loss of appetite. Other patients report diarrhea. Some also report constipation. And some will even have systemic side effects like headaches or insomnia, irritability, feelings of chills, etc. I think the biggest designation that's important when we talk about dysmenorrhea is the designation between primary and secondary dysmenorrhea. So primary dysmenorrhea is simply the inflammatory response to having an ovulatory cycle. To some extent, it's quote unquote normal. but that doesn't mean that it's not painful. And the reason that this happens is when you have a corpus luteum that has involuted after ovulation. So on the left side of our drawing, after the corpus luteum has completely involuted, the corpus luteum basically provides progesterone in the event that there would be a pregnancy. So when the corpus luteum involutes, there's a massive drop-off in progesterone. And when that drop-off in progesterone occurs, there is then release of prostaglandins and leukotrienes, getting us to this algorithm that we all may not like to think about for medical school. Prostaglandins are important because they cause vasoconstriction and myometrial contraction, which to the body or to our patients presents as ischemia and pain. But they also cause surrounding pelvic inflammation. So this is the reason why other patients can have diarrhea, they can have nausea, inflammatory symptoms. I basically describe this to my patients as having inflammatory release in the pelvis that's just causing everything to be exceptionally irritated. Going back to this cycle, the progesterone withdrawal as well as the estrogen withdrawal that's happening during menses is also part of the reason that patients can report some of the systemic side effects. Like estrogen withdrawal is known in some patients to cause headaches. It can also be the reason for insomnia, irritability, etc. So ultimately, it all comes down to hormones, but it also is a big inflammatory release for our patients. Secondary dysmenorrhea is also an inflammatory response, but it's an inflammatory response to a structural pathology. So some of the structural pathologies that I see are endometriosis. This is when the endometrial glands that are in the inside of the uterine cavity expand outside of the uterus to the serosal lining, to the tubes, to the ovaries, and the peritoneum. But this can also be because of a Müllerian anomaly, particularly those that are obstructed, or ovarian cysts or pelvic adhesions. So when we talk about primary dysmenorrhea, I mentioned that a lot of this goes back to hormones, but I always like to remind our patients that treatment strategies for primary dysmenorrhea don't have to be hormones. There are lots of other ways to try to treat primary dysmenorrhea first. So NSAIDs are the classic way that I will try to first treat primary dysmenorrhea. My favorites are using ibuprofen or naproxen. I tell patients to use these scheduled around the clock every 6 to 8 hours. I recommend doing it for the first 24 to 48 hours of their period. And if they really have predictable periods or they have a sign that their period is coming, breast tenderness, irritability, anything like that, to start the medication then prior to the sign of bleeding, because often the pain will start when the bleeding starts. Other patients have success using heating pads, and TENS units, which used to be hard to access, are now available on Amazon, and some patients do have success with TENS units. The one thing I'll say about this is there have been new marketed TENS units, like the one pictured here, that are specifically for dysmenorrhea. These can be a little bit more expensive. The pink tax is real. But on Amazon, you can get TENS units that are not necessarily marketed for dysmenorrhea that can improve dysmenorrhea in the same way. They are essentially the same. The nice thing about some of the more expensive or the ones that are more marketed towards dysmenorrhea is that they tend to be wearable and very small and discreet. So some of my patients will try to wear them to school, etc. Exercise has also been shown to decrease dysmenorrhea, and a variety of exercise techniques have been tried in research studies. Yoga or more aggressive cardiovascular exercises all have been shown to be successful. I think the hardest thing about prescribing exercise for dysmenorrhea is that when you're in pain and when you're bleeding, exercise is sometimes the last thing that you want to do. So it can be sometimes hard to get uptake from our patients. And then every once in a while, I'll have patients that will ask me about supplements or dietary changes. There's been some research into vitamin D as an anti-inflammatory agent. Does that help dysmenorrhea? There's certainly herbal teas that some patients will report helps with their dysmenorrhea. And also, if you are on TikTok or on Instagram, you may see ads for PMS gummies or other types of supplements that have been more common recently that have a variety of antioxidants, et cetera, in them that haven't necessarily been proven to help dysmenorrhea. But my rule of thumb with my patients, if you feel comfortable, you can try it. If it works, great. If it doesn't, we can try some other things. If the non-hormonal options work, then my next step is to go to hormonal treatments. Now, before I go through all of these, I'm going to say, I told you at the beginning, I don't have any disclosures. I am not hired by any of these drug companies, but I do think that it's helpful sometimes to be able to show exactly what I typically use in the office. So when I think about hormonal medications, I think about them in two categories: our combined medications that have two hormones, estrogen and progesterone. Estrogen makes a cycle regular. So these are going to allow for regular cycles, monthly, every 3 months, every 4 months, etc. Progesterone only does not have estrogen. The one thing I can guarantee with those medications is you will not have a regular cycle. And so these medications really shine in terms of trying to make periods go away for menstrual suppression. But for some women, they can have irregular bleeding profiles. So in terms of the combined pills, the most common pill that I use is one that's called Cresel. I think the most important thing to me about hormonal medications or hormonal pills is that I really try to make sure that we're always using 30 micrograms of ethinyl estradiol. The difference in pill formulations in terms of estrogen is going to be the amount of estrogen, not the type. It's always ethinyl estradiol, and it's just going to be the amount. There have been some small studies that have shown that less than 30 micrograms of ethinyl estradiol may lead to decreased bone mineral density in our adolescent patients. So I try to give a minimum of 30 micrograms. And so that's generally where I start. Pills also then change in the type of progesterone, and it's the progesterone component that has the added benefits, whether or not it may help with acne. Most help with acne. Some, drospirenone, which is a type of progesterone, is a little bit better at acne. Some may have other side effect profiles in terms of mood changes, etc. So sometimes I tinker with the type of pill based on the type of progesterone that's in them. If I have a patient that's having side effects or they're trying to get a certain effect out of that that's beyond just period relief. So I try generally Cresel. Junel is another common one. Junel, just be careful. The most common Junel is a 1 and then 20 microgram ethinyl estradiol. So always make sure that I'm ordering the 30 ethinyl estradiol. There's only one monthly ring that's out on the market, and it's the NuvaRing. And then there are 2 patches that are available. Xulane is tried and true. Twirla is a little bit newer, but it does have slightly less ethinyl estradiol. Because of the way that the patch is taken up, the 30 micrograms of ethinyl estradiol in the Twirla is probably adequate. So I've tried it with several of my patients. The problem is it's newer, doesn't always get approved by insurance. So if you want something that you're certain is probably going to go through, Xulane is where it's at. In terms of our progesterone-only medications, the difference between these 2 medications is really whether or not they've been FDA approved as contraceptives. So Micronor, yes, FDA approved. Agestin, it probably works as contraception, but it is not FDA approved. So that always comes with that warning label for any of my patients who may be sexually active. And Micronor has more commonly a risk of irregular bleeding. Agestin, which I titrate often up to 10 milligrams if needed, is really good at suppressing periods. So I use Agestin when I know a patient is having so much pain that we just really don't want to be having periods. Depo-Provera is the only injection that's available. It has a really common side effect profile of having irregular bleeding, particularly in the first several months. That gets better after about 6 to 9 months of use. I do sometimes give this every 2 months initially to expedite amenorrhea. And another fun fact about Depo is that it can actually be given sub-Q. So some of my patients who prefer to give this to themselves at home or going off to college and want to have a little bit more control, I can do sub-Q dosing. I can teach them how to do sub-Q dosing. And then our long-acting options, the Nexplanon is kind of a sister to your Depo. And then the IUD, I use either the Mirena or the Liletta, anything that has 52 milligrams of levonorgestrel. So I am not a fan of the smaller IUDs, the ones that have less levonorgestrel in them. And the reason for that is that they have more breakthrough bleeding, and any uterus that is menstruating can accommodate the size of IUD that has 52 milligrams of levonorgestrel. And for me, IUDs are something that can be placed in the office, they can be placed in the OR, and there is no age requirement for placement. You just have to be menstruating. There you go. Okay, so you all are in the office, you have been treating somebody with primary dysmenorrhea. And I think that that's the other important statement to note is that I treat all of my patients as if they have primary dysmenorrhea when they come to me for the first time with painful periods, unless they've been receiving treatment elsewhere. But if they've never received any hormonal medications, I treat them as primary dysmenorrhea first. So then I'm always on the lookout for what are signs of secondary dysmenorrhea. So I look for worsening pain over time, particularly if the pain is worsening in duration. And this is important because I think about this less in the early adolescents who have just started menstruating, who are having irregular periods. Those patients, when they start having regular periods and they're having ovulatory cycles, may then start to have pain. But in a patient that's had regular periods and they're suddenly having pain, or that pain is getting worse despite those regular periods, that's a warning sign to me. If a patient is having pain despite the use of hormonal medications, so if they're using COCs and during their withdrawal week, they're having pain that's requiring NSAIDs around the clock, or they're using continuous medications and they're still having pain, if they're on depot and they're still missing school, those are warning signs for me of secondary dysmenorrhea. If they have pain that's starting more than 24 hours before their period is starting, or pain that's occurring before their periods that feels just like the pain with their periods, that's a warning sign. And this is a little bit of a softer warning sign, but patients who are having recurrent painful hemorrhagic cysts, who are coming into the office complaining of recurrent pain 7 to 10 days before their periods, or they're being seen in the ER and urgent care with repeat ultrasounds that are showing hemorrhagic cysts, I start to worry about secondary dysmenorrhea. So for me, secondary dysmenorrhea or concerns about secondary dysmenorrhea are what warrant ordering a pelvic ultrasound. And what am I looking for that? So the most rare finding that I'm going to be looking for is an obstructive anomaly. So, and I think the important thing about this is we often think about obstructive anomalies when a patient isn't yet having periods, when they are pubertal, not yet menarchal, they're having pain, it's cyclic. But it's really important to remember that periods do not completely rule out some of our Müllerian anomalies. So in the pictures below, in the first picture, this patient has duplication of the uterus and a vaginal septum, but this anatomy allows for menses to egress from both sides. But on the other picture, this patient also has duplication of their uterus, duplication of their cervices, and a vaginal septum, but this vaginal septum is obstructing, meaning that they will menstruate on their left side. I was trying to figure out which side it was for you guys. They will menstruate out of their left side, but they will obstruct on their right. So they will have periods and they will have progressively worsening pain. And progressively worsening pain that's then extending outside of the menstrual cycle, is really a good sign for an obstructive anomaly because that blood will slowly build up more and more and more. The best way to diagnose this is on ultrasound, where you will see hematoculpose. So in the ultrasound image below, you can see the uterus looks quite normal. There's maybe just a slightly increased endometrial lining in the center, but the big black circle that you see at the bottom is actually the vagina distended with blood. Whenever I see hematoculpose on an ultrasound, I order an MRI. And so the MRI picture you can see as well, the uterus with a thin-ish, slight increased endometrial lining, but a large volume vagina that's been completely distended with blood. And this uterus is now then been pushed high into the pelvis because of that hematoculpose. This is likely a patient that either had a low transverse septum or an imperforate hymen. The other thing that I think about with secondary dysmenorrhea, or what I might see on ultrasound, are hemorrhagic or physiologic cysts. And what I like to remind patients is that physiologic cysts are normal. They are what your body is supposed to be doing. A physiologic cyst develops with the menstrual cycle, in order to house an egg and nourish an egg, as I tell my patients, and it will pop at ovulation. These typically grow to be about 2 centimeters, but occasionally these cysts can get larger. I've seen them as large as 6 to 8 centimeters, and they sometimes cause pain just with enlargement, but the most common thing that happens is when ovulation occurs, they rupture, and when they're larger, rupture causes bleeding, and bleeding causes pain. And so this is the classic hemorrhagic cyst. So that's happening right about this time. Because of the timing of ovulation with the menstrual cycle, these pains typically present about 7 to 10 days before a menstrual cycle. Um, and they typically resolve within 2 weeks, but I've had some patients have pain up to about 4 weeks after. It typically presents with sudden, severe pain that slowly resolves over time. On these, you can see on pelvic ultrasound, this is going to be a simple physiologic cyst, but others of these cysts that have had some bleeding, you'll get kind of these lace-like internal echoes that show bleeding that's happening or hemorrhage. And this is something that can very much be managed in the primary care setting. For these patients, I monitor their pain. If their pain is steadily getting better, if they're not having nausea or vomiting, and they're able to manage everything with NSAIDs alone, then I simply get a repeat ultrasound in 6 weeks just to show the cyst is gone. It proves it was physiologic. You're good to go. Most patients will not have recurrence of their hemorrhagic cysts, but certainly there are some patients that do have recurrent hemorrhagic cysts, and then that raises concern to me for the next form of secondary dysmenorrhea. So endometriosis is one of the most common forms of secondary dysmenorrhea, and it's a pain condition associated with the growth of the endometrial lining outside of the endometrial cavity into the serosa of the uterus, the tubes, the ovaries, onto the peritoneal covering of the bladder, of the bowel. The important thing about endometriosis is that it's progressive. So in adolescents, when we look on laparoscopy, we don't necessarily see endometriosis like we do in adult women with scarred in posterior cul-de-sacs, with large endometriomas. Those are quite uncommon in teenagers. This can be very subtle. So some of the worst endo that I see on laparoscopy is seen with these small little chocolate lesions, or in the lower picture, these what we call powder burn lesions. So these little dark lesions surrounded by a little bit of white or red. They can be red lesions, they can be white lesions, but they can be incredibly subtle. And that is a slam dunk for endometriosis. It can even be even more subtle. So in this patient, just this area of a little bit of hypervascularity sitting on top of the bladder is endometriosis. Or in the picture in the bottom, again, those little punctate hemorrhages sitting just on the top of the uterus and on the serosal covering of the bladder, that's endometriosis. So this can be incredibly, incredibly subtle when we look on laparoscopy, which I think is an important thing to note because you cannot diagnose endometriosis in adolescents on ultrasound or MRI. We've made some moves in adult women in our ability to make those diagnoses based on imaging, but because of how subtle this can be in teenagers, it's almost impossible to see on imaging. So how do I know that endometriosis is there? Well, the gold standard is diagnostic laparoscopy and biopsies. But in order to get to that point, I have to have a raised suspicion. And raised suspicion comes with continued pain despite the use of hormonal medication, or pain that feels exactly like their period pain that's happening in between their periods. If a patient has endometriosis, I will try a number of medications to treat this, hormonal medications. You can use continuous use birth control pills. These are also patients that I'll use agestin in, or sometimes I will stack agestin on top of an IUD or try to use an IUD alone. In the most refractory cases, I'll use Depo-Lupron to shut down the entire HPO axis for 6 months to 2 years, but always with add-back agestin to support their bones. Surgery is also a mainstay of treatment, but it's always used in conjunction with medication. Any patient who receives surgery from me and has fulguration or excision of their endometriosis will ultimately still go on hormonal medication to prevent the progression of endometriosis after surgery. And then certainly we work in conjunction with pelvic floor physical therapy. We do Botox injections of the pelvic floor because all of that inflammation and irritation can certainly lead to hypertrophy of the pelvic floor muscles and ongoing pain, bladder spasm, etc. And then we also refer to pain management or pain psychology to work on our neuronal signaling about pain. The reason that I wanted to talk about endometriosis today is that, one, it's progressive, and two, it can't really be diagnosed without really high clinical suspicion. And I think that this is a really great way that we can work together as primary care providers and specialty providers to really be able to ultimately change the trajectory of endometriosis, because this is something you have to think about in order to diagnose. And diagnosis means long-term treatment with medication that may prevent the progression of a disease that ultimately can lead to significant missed school, missed work, repeat surgeries, infertility. So it gives us the opportunity to recognize this in teenagers and change the course of their gynecologic care throughout their life, which I think is really important. So with that, dysmenorrhea is common. Primary dysmenorrhea can be managed in the primary care setting with minimal additional workup. And pain that's occurring despite hormonal medication should be a warning sign for secondary dysmenorrhea and an indication for pelvic ultrasound or referral to gynecology. And this is my information. I know there's a couple of you in the crowd that I often email back and forth with. You are welcome to take my email. I'm always happy to email about patient cases. This is also our team email and our team phone number. So if you have patients for referral or you're in the office, you have an ultrasound finding and you need kind of an urgent review of that, you can always call these phone numbers. We are more than happy to help. And just a reminder that we see patients all over the DMV. So if you need us, that's where you can find us.
We do have time for a question or two. Please introduce yourself. Yeah.
Hi, I'm Susie Jadovitz from Frederick. Just given how subtle endometriosis can be in adolescents, should we feel comfortable referring to our community, primarily adult gynecologists, if we have an adolescent that we're suspicious, or should they be going to pediatric gynecology?
I think that's a hard question. I think that if they have ultrasound findings, so, like I said, it's progressive, it tends to be very subtle. In patients who have had recurrent hemorrhagic cysts, they may have findings on laparoscopy that would be really consistent with adult endometriosis. But we do have some studies to show that, because I can stand on my horse because I was an adult gynecologist before I was a pediatric gynecologist. Adult gynecologists are really used to seeing very progressive endometriosis, and some of these most subtle findings of endometriosis, it's been shown, can be missed in the adult setting. So I do think that it's valuable, but I also recognize that there are only 5 of us, and sometimes, and we circulate closest to the DC area. We may not get always out as far out as Frederick. And so the most important is that a patient is being seen and having their pain heard and having these options given to them. And so if that's what it takes, adult OBGYNs are great. They do know how to treat endo. It's just that we know that some of the subtle findings are a little harder to pick up when you're used to seeing very severe endometriosis on laparoscopy.
Hi there, I'm Ashley Moss in Chevy Chase. Thanks for this great talk. A quick question about birth control pills that are being used sometimes for acne. Actually, I think Yaz is frequently used, which is 20 micrograms. Do you recommend
Yasmin.
switching to Yasmin, which is 30? Okay. Does it have the same positive benefits for acne?
Yeah, so Yasmin still has drospirenone. So the progesterone component of birth control pills tends to be the anti-androgenic portion. And so Yasmin has drospirenone, the same amount of drospirenone that's in Yaz, but it just has the 30 micrograms. So that's what I tend to use.
Thanks.
Mm-hmm.
That was awesome. Look at that. All right. As we continue to sort of work our way through conditions that you commonly see in primary care practice, we're glad to bring up a presentation team from both cardiology and primary care, talking about chest pain in children, to refer or not to refer. And we have Dr. Harahsheh from cardiology and Dr. Dubelman from primary care. So take it away, guys. The green thing advances the slides. Right, and we'll back it up. Just make sure you're speaking in the mic.
Okay, thank you so much. And good afternoon, everybody. Can you hear me there? Okay, awesome. Okay, perfect. So we are in good shape here. Thank you so much. I just have one disclosure. The timing of my presentation coming after this OBGYN might get me dizzy and faint. Thank you, Mark, for that. For the records, I became a cardiologist because I don't want to care for anything below the diaphragm. So this talk was really, we have no other disclosures. Usually when a cardiologist comes with his partner pediatrician to talk to you about chest pain, we try to put the scare of God in your heart. So we share with you these pictures. We talk about the athlete who dropped on the field from hypertrophic cardiomyopathy. We talk about the kid who got her first kiss and then had a fainting episode / died from long QT or Brugada syndrome. The goal of this is to get you excited, scared, and then my boss become happy with me with all the number of referrals of patients that you send to me. But that's not what we're going to do today. We will talk about the common causes of cardiac disease. And by the end of this talk, you will see with me that it is so rare for us to have a cardiac diagnosis in the majority of the children who present with chest pain. We will talk about when should we refer a patient with chest pain to cardiology versus keeping them within your medical practice. And finally, we will touch base on some QI work that was done at local pediatricians' offices, namely the Children's National Pediatricians and Associates. Eli Hamburger, if you are here, raise your hand. Okay, she's not here now, but this work was really because of Eli and her team and all the pediatricians in the Children's National Pediatricians and Associates. I'm so grateful for all of you. Thank you all for your help over the years. So we'll start with this case. This is a 15-year-old who presented with chest pain during activity. Mother has depression. Maternal grandfather had a heart attack at 50 years of age with a normal examination. This patient was referred to cardiology, and we did find an underlying cardiac disease. I'm going to share with you the normal heart structure. I guess you cannot see my mouse. So in this normal child, the aorta is in red, the pulmonary valve is in blue. Coming from the right sinus of the aorta is the right coronary artery, where it should be. And coming from the left side is the left coronary artery, where it also should be. In the children that have an underlying coronary artery problem, they might have the left coronary originating from the right-facing sinus or the right coronary originating from the left-facing sinus. In either way, you have a coronary artery in between the two almighty great blood vessels. When we exercise, we fill those blood vessels with volume, and that can squeeze the coronary artery, cause arrhythmia, sudden death, syncope, fainting, or chest pain. This particular patient had the anomalous right coronary artery of the left-facing sinus. So in this particular case, going back, the thing that was the trigger point was the chest pain during activity. We talked to the family, we got the history, and the history was he was actually running when the chest pain happened. So when you are talking to families, it's not enough to say chest pain during gym class, for example, because he could have just was standing, was not doing any physical activity.
So as you can see, it's in red. I'm Ari Dubelman. Hi, everybody. As you can see, it's in red. This is considered a red flag criteria. And so what we're going to show you are going to be going through the different cardiac causes of chest pain. But one thing that you'll hopefully get by the end is a sense of what are the types of chest pain that would be cardiac, what would not. And as you go through it, you're probably going to hear a lot of things you've heard before about cardiac chest pain, and you might even say, I've seen that, I know that. The trick is to know that at the right time in the right kid, and to feel really good about the fact that you have ruled it out by history and physical as best you can, or that you can't rule it out based on the red flag criteria that's part of that kid's presentation, and that that's a child that should go to cardiology. So I can tell you from the primary care side that, as we go through this, we instituted some of the things that we learned from Ashraf and his team, and as part of that, and it was helpful to solidify things that we knew and be able to access that kind of information from our heads in real time, and try to figure out who are the kids that really need to go and who don't. And with that, I think coming up with an understanding of who really does need to go, so that we feel really good about the fact that we referred an appropriate child, is step one. And then figuring out that they do or don't have those red flags will be step two. So cardiac causes of chest pain are listed here, and certainly Ashraf and his team can speak to how those kids present best, and what those types of chest pain would look like. But these are the types of things that would present with red flags that we'll come up to shortly.
Thank you. So when should you refer a patient with chest pain? And this is where the red flag comes in. And, most of the kids with true cardiac disease explaining chest pain were identified in this red flag criteria. We have never had a patient who was discharged from cardiology with benign type of chest pain have an underlying cardiac disease or succumb to a cardiac disease later. We have data, 18,000 patient years worth of data showing that this red flag criteria is accurate and true.
To reiterate, that means that if you have this, you should refer, and if you don't, all of these things we're about to go through, then you really don't have cardiac disease, and then we just have to redirect our efforts to say what you do have instead, and feel comfortable, at least from our point of view, that this is not a cardiac patient and doesn't require referral. So exertion's a big one. So that was the case we saw before. Chest pain with exertional syncope. These are going to sound familiar to you. Also think about the nature of the pain, a cardiac origin of pain that might radiate, as it does here in this line to the jaw, the left arm, the left shoulder. And then the other thing that we're going to touch on are chest pain associated with an acute presentation of illness, such as what myocarditis might do and the like. So in typically a chest pain that seems to worsen in the supine position or associated with fever at the time, you have to keep that in mind. We do have to keep in mind any past medical history relevant that might make you think harder about that chest pain. So a child who's been immobilized for long periods of time, or might be in a hypercoagulable state, or have vasculitis history that might bring that to your attention. And never forgetting about the family history. We certainly have been taught to, as we screen our routine kids for a checkup and trying to identify who is a healthy athlete and who might need cardiac referral, we talk about sudden unexplained death and in the family, or cardiomyopathy history in the family, or a family history of hypercoagulability. And then the physical exam being abnormal in the ways that you might think about and might grab your attention. So murmurs that don't sound very innocent to you, or things that are occurring at a time of an acute illness, with a chest pain at the time of the fever and the ill-appearing child. Of course, gallops and friction rubs, and we don't commonly see, but those would probably, I'm sure, raise your eyebrows if you did. Peripheral edema. So the trick is taking a slide like this, and hopefully that slide will be available to you, and being able to look at those things and say, yes, that makes sense to me. I can understand that child, if they have these things, should require a referral. How do we gain confidence in the majority of the other children who present to the office with chest pain and really don't have these symptoms? The most common patients we see don't have these symptoms, don't have these signs, don't have this history. And so their cause of chest pain is going to be non-cardiac. And then and that is a primary care then entity of chest pain, not a cardiology origin. And maybe they have other non-cardiac things to address. And how do we gain the comfort level in knowing who doesn't really need referral as well, which is part of what we're going to get into in the talk more, is how did we translate from the project we did information we had in our heads and knew about this to being able to make decisions that make sense for that patient, and bring the anxiety level down in the room a little bit. So chest pain, usually they're coming in anxious. Either the child is, the mother is, or sometimes we are, about the patient with chest pain, in particular if they're not the greatest historians, or you couldn't drag it out of them well, or they contradict themselves a little bit, or they went to the ER or something along those lines. And then we have to remind ourselves kind of our systematic approach to ruling this patient in or out for cardiac disease and then taking it to the next step. So having something to do in real time to help us in a little bit more of a checklist fashion is something that we fashioned and we'll get into shortly. And it was based on this slide. And this slide was based on the studies that Ashraf and his team did that basically said that in the absence of these, the chances of cardiac disease are practically none. And with these, it's still low, but maybe a cardiologist is warranted then.
Thank you so much. I want to give credit to Mark Weissman, who a couple of years ago, when I had black hair, he shared this slide with us, and he taught us that things are changing, and that if we don't change, we will, basically we will be forced to change. As many of you know, it's in your best interest to keep those patients within the practice if they don't need a true referral to cardiology. That will help us see the other children who actually need to be seen within cardiology. The days of us doing more testing means more pay is going away or is gone. So it's more about value-based care. Dr. Lily Hamburger had done work on consultation and referrals. And one of the things that I learned from her work with pediatricians is that some pediatricians identify that there is a lag in the knowledge of the red flags when to refer a child with chest pain or syncope or headache or ear infection or etc. And that's something that we subspecialists and you pediatricians, we need to come together to help each other come up with this. So in this particular exercise, we had 3,167 children who presented with chest pain, and only 8 of them had a true cardiac disease. So it's 0.25%. The joke I say is that now when I see a chief complaint of chest pain in my clinic, I have a big smile. I know that I will be giving good news in the majority of those children. What we did in this exercise, we divided the group into 2 groups. Group 1, basically, they had at least 1 red flag criteria. Group 2, every single item that Ari shared with you was negative, so they had no concerns. And all the patients who were identified to have cardiac disease belong to group 1. In group 2, the ones that we are advocating to be kept in the practice, they had 0 cardiac disease explaining their chest pain. I'm using my words carefully. I'm using the term cardiac disease explaining chest pain, and you will see why I'm using this full sentence. If you were to apply this in your upcoming visits, let's say next week when you see a child with chest pain, you will have 100% sensitivity in picking those with true cardiac disease. From this, we took this tool and embedded it within the EMR of the local pediatricians. We started with Lily Hamburger's practices in DC, and then we expanded. I'm going to share with you a couple of slides here. Our aim was to reduce the low probability referral from the general pediatrician's office to cardiology down to 5% by the end date of that QI project. We had a multidisciplinary team. There was multiple pediatricians. I'm not really sure. If any of you were part of any of the work that we had on chest pain, please raise your hand. Okay, excellent job. Yes. Okay, thank you guys so much again for all the hard work that you have done. I mean, this is truly your work. And then we had a QI coach. We had cardiology and a couple of residents and chief residents involved with this project. Our process measure was to improve the utilization of the decision support tool, something that is just really awesome and cool. I'm very grateful for ItSafe for helping us put it up in the EMR. Our outcome goal was to reduce the low probability referral. And of course, we had to have a balancing measure. We needed to know, are we doing the right thing or not? How often did we pick up cardiac disease or life-threatening event in those who we said don't need to be referred? And this is the decision support tool.
So everybody's EMR is different. Everybody's EMR is easier or more difficult to manipulate to get to do what you want it to do. But this is the way that we were able to do it. We had very technical savvy folks put together a form. So our particular EHR at the time used forms as one of the methods of trying to get your data into your chart. Others use, favorites or quick text or whatever you have. But this was a form, and we basically took the information off that slide and put it in a yes/no checkbox format while we were doing intake. So I'm in there with a patient. The patient's chief complaint was chest pain, or it came up in the visit that was what they're there for. And I was able to quickly load this form up as part of my intake. And just as I'm taking history, check the yeses or nos, check the yeses or nos. And most of the time, it's nose down the row. And if I can get a nose down the row and none of those red flags are there, then I, at least at the end of the visit, feel very comfortable that we've ruled this patient out for cardiac disease, that the chest pain we have, I've done an exhaustive list. And for that patient who came in anxious and changed the tone of the visit and or was already worried or made us worry, then I have this available and I've improved my own confidence, which is step one. So once we have provider confidence that we really don't have a cardiac patient on our hands, then we can translate that to really redirecting the tone of the visit towards what do we have if we don't have cardiac disease, and start focusing in on that. And then hopefully bringing some reassurance and decreasing the referral rate for patients who didn't really need to go, which we were able to show that we were able to do once we incorporated this and reminded ourselves to use it. The EHR, you have to remind yourself to use it. But we did that, and that's how we did it. And this could probably be translated into other domains. So like, for example, you could take this list, put it into a favorite or a quick text or a phrase that you enter automatically, and then have that already in your note, and then start to go down it and check it if that's helpful to you. Some tool like that. I also imagine that expanding this to other talks we've had today, a similar tool could be incorporated for red flags in other areas. And this was something that we were able to show, at least with this particular chief complaint in this particular list, given that we knew that the probability of cardiac disease when they're all no is good, that we could incorporate well. And then conversely, if we had a yes, we knew to refer.
Thank you. So it took a teamwork on this. This started with data collected from 2015 up till 2018 for the phase 1. And you will see multiple process control charts shared with you here. This is different intervention that we had to do to get the utilization of the tool increased at the practices. Along with that, there was an initial drop in the low probability referrals. Like any other good QI projects, you will sometimes get that when people think that they know the tool and they don't want to use it anymore. And then what we noticed was that there was a reduction, and the reduction correlated with the utilization of the decision support tool. So from this phase 1, we expanded to 3 other practices in Maryland, again, part of the Children's National Pediatricians Associates. And now we have a larger group of pediatricians and nurse practitioners, and we saw a similar improvement. The expanded phase was finished. We are kind of we're lucky enough that it actually finished as COVID hit us. So we were not impacted by COVID. Those patients were all seen in-person visits. And along with that, we had a nice reduction in the low probability referral through multiple interventions with a larger because of now we are having 4 or 5 practices. At the same time, we saw this increase in the utilization of the decision support tool. Now, the big question here is, okay, you did a nice job, you reduced the low probability referral, but what happened to the patients who did not get referred? Did any of them have any cardiac disease? Or for those who did not meet a referral, did cardiology find anything? And we had 3 patients who we did find a cardiac condition. I'm going to continue to say that the cardiac condition that was found was not related to their chest pain. So this is a follow-up that we did. It was a 1-year follow-up for this particular QI. And with that, we had those 3 patients. The first patient was referred, and the reason for the referral was the child was too tall. The pediatrician said in their assessment that this is a benign chest pain, but the child is tall, and I'm worried about Marfan syndrome. My joke there is that he was as tall as he was now 3 months ago when you saw him for the will visit, yet he was not referred at that time. So he came in, he was diagnosed with a bicameral aortic valve. There was no aortic stenosis to explain the chest pain. The second patient had a premature ventricular contractions. So we did a Holter, and on the Holter, we saw 2 different morphologies. But then after that, he had a normal stress test. So again, this does not explain chest pain. And the last patient was an incidental finding of Wolff-Parkinson-White syndrome. Those patients are going to be followed by cardiology. They are going to be labeled with benign chest pain, and they, doing very well. So why does low probability referral occur? We asked the pediatricians when they decide to refer and they did not meet the criteria to give an explanation.
So in going back, so if we referred somebody, but we used our checklist, we were trying to figure out what is it that made us refer anyhow. So some of it was still provider with a concern. So something about the presentation just made that provider a little less comfortable when it was all said and done, even though they had no's in their checkboxes. There's certainly a component of parental and patient concern that initiates referral, even if we feel very confident. And so that certainly happened. Patients with other cardiac symptoms. So for example, you would have had a chest pain presentation, but out of that, we learned about other syncope or something else that would have then initiated that referral, or the non-PMD providers initiating the referral. This is the patient who goes to the emergency room with chest pain. They get their ER workup, and nothing is found, but the ER says you should probably follow up with cardiology, and so that's then where they go. And then sometimes we didn't have a reason found for that. So in this, we would try to find reasons why, and this is one of those examples. So the appointment was they came in for an emergency room follow-up visit. We heard the story again, examined the patient, and ultimately determined that we didn't feel their that the chest pain was cardiac in nature. But at that point, they had been referred to the ED, who found what they believed to be LVH on EKG. And so basically the train had already left that station and they were on their way to the cardiologist already. And you can see some of these other etiologies here that came up. And this is the kind of thing that often will result in referral.
Okay, thank you so much. And just for clarification, I want all of you to hear me say this. One of the drivers for referral from pediatricians to cardiology is parent anxiety, parent concern. It's the same drive for unnecessary testing in the cardiology practice. So when we looked at our cardiology group, I'm talking about 13 academic and community centers from Boston all the way down to Children's. One of the drivers for doing an echocardiogram when it was not indicated was actually parent concern and anxiety. So I just want you to know that we are on the same boat as far as dealing with parent anxiety and concerns. We're going to change subject to talk about a different patient. 15-year-old Jane presents with chest pain. The pain was not exercise-induced. It was not associated with any other cardiac symptoms. It did not radiate up to the neck. It was not worse with laying down. And it was aggravated by breathing. Her examination was completely normal, including reproducible pain on palpation. The family history and past medical history were all benign. You explained to the family that this is a benign chest pain, and the family were kind of insistent on being referred to cardiology, tapping on the floor, for example, or putting their hands up like this and telling you, we need to be seen. I'm going to share with you some things that I have learned working with our residents. So one of the simulations that we do is we hire actors to teach our residents communication skills related to this scenario. So what we would do is the actor at this point will tell the patient, will tell the resident, well, how can you be sure that my child is not going to be the next one dropping on the field? Or I just read on the news article and there is this famous player who dropped, etc. How can you just be sure 100% that this is not going to happen to my child? And, our residents are, variable, and I mean, I really enjoyed working with them. And a couple of the residents highlighted a couple of things. So the first one was, the first thing that she would say is, I'm glad that you came here today. This is the place to come to know whether we need to go to cardiology or not. Another resident, after counseling her through the work that we have done, that we are part of this QI project. We worked with cardiology. We know when a child needs to be referred. And based on the criteria that cardiology had done, we know that you don't have a true cardiac disease. The presentation of the person in the field is very different, and this is why it is different. And then one resident would say, I have a very low threshold to refer people out, but in this particular case, I'm very confident in actually not referring you out. I don't really think you need to be referred. Ari, any points about when not to refer?
We sometimes will win and sometimes we'll lose this conversation. We know who we're going to lose with sometimes before we even walk into the room. And what are you going to do? But there are patients where their anxiety is real and we have to get to the bottom of where it comes from. So, maybe it's just that they have seen a lot of stories about it on the news and that's the origin, or maybe they maybe they come up with some other concern, and possibly that we missed a family history in that conversation. They say, well, my uncle, had this happen to him when he was, 20 years old. Well, now we have a family history we weren't able to tease out before. Maybe that patient should go. But in most cases, it's going to be more just that they think that's the next step, and that's what they want to do. And I do think that some of the things that those residents were sharing are excellent points. I do think that the more that we present a confident air about it ourselves sometimes helps. Not so much to say that, we know everything and we know best kind of air, but more just like, oh, I feel good about this. I feel good about the things you're sharing with me. You told me a lot of good things. We asked a lot of questions and all the answers were good ones. We did not hear the things that cause these, that cause these cardiac conditions. We did not hear, it's just not the way they behave. It's just not how they present. And so the type of chest pain you're having really is not fitting that. So let's talk about what it does fit, and try to really kind of steer the conversation to that.
So we want to conclude with the red flag criteria. Please take a picture. Hopefully, this will be embedded in your EMR as well, and you can use it and utilize it for your patients. Feel free to reach out if you have any questions. You saw there are many providers who had participated in this before. So if you don't trust me, trust this man. He's a good guy. So this QI project, we believe, was safe, effective, and feasible. And I'm grateful. How do I go back? Do I go back?
Maybe
Oh, here we go. I just want to put the names of everybody who participated in this before. How many seconds do I have? Okay, awesome. Any questions? Any questions? So in anticipation of lack of questions, I'm going to give you questions. So here's a first case. Now I need a volunteer to come up with an answer, okay? So we have an 8-year-old girl who presented with a retrosternal chest pain for 1 week. Her examination is normal. Of the following, what is the one finding that would suggest a cardiac disease? Is it a sharp stabbing pain, pain that happens only at rest, pain that happens aggravated more with inspiration, or pain that happens with exercise, or if there is reproducible pain on palpation? A, B, C, D, E. D. Okay, wonderful. So I hear D loud, and that's the correct answer. So this is the criteria again in the HPI, exertional chest pain, true exertional chest pain. I make a joke. I feel like sometimes I'm a CSI agent. So please dig deep into the chief complaint. Feel that you taste it, you feel it, you lick it. You know what the chief complaint is, okay? And then the pain radiating to the back, all of these are concerning. Pain worse with laying down goes with pericarditis, and then the last one goes with myocarditis. Now, that's question number 2 is a chest pain in a 15-year-old. The chest pain was not radiating, not related to sports. Family history is reassuring. Examination is normal apart from reproducible pain on palpation. After explaining the benign nature of the chest pain, the mother became angry, mandating a referral to cardiology. The most appropriate next step is? Just go ahead. What's one another patient refer to cardiology? Just go ahead and refer cardiology. Call Dr. Ansong. Raise your hand, Dr. Ansong, and have her see the patient. Refer to the emergency department. Ask the family to see another pediatrician. Obtain an EKG, or DE, determine the concerning element. I mean, I know it's easily said than done, but honestly speaking, sometimes it's all about the concerning element. I'll give you some examples of concerning elements for patients who did not meet did not meet the need for echocardiography. I saw this child, she comes in, I reassured the mother, this is not life-threatening, this is benign, and then the tapping happened, and then I was like, okay, I'm sorry, I'm losing it. So tell me more, why are you here? Let's talk about what concerns you, what's make you up, keep you up at nighttime. And she told me, it's the mold at the school. And I was like, what mold at the school? She's like, well, my child started having chest pain when she started at this new school. I need a note from you to say mold at school can be associated with chest pain, so I can move my child to another school. No echocardiogram would have been able to do that, okay? Last case, 16-year-old with chest pain. Chest pain occurred while the child was sitting. You decided not to refer to cardiology. And then a medical student, I love these type of questions, by the way, for the board. I love them. Medical student asks you about cardiology referral criteria for patients presenting with chest pain. In answering the medical student, which of the following is true? A, majority of patients referred to cardiology with chief complaint of chest pain have an underlying heart disease. B, about 30% of children with non-cardiac chest pain have associated panic disorder. C, no red flag criteria have been developed to help us refer those with chest pain. D, all patients presenting with chest pain should see cardiology. And E, all patients presenting with chest pain should be exercise restricted. What's the least wrong one here? B. Okay. So the answer is B. There are multiple studies looking at this. One of them came from Emory, which I really like. What they did is when the children presented to cardiology with chest pain, they took them to the psych office and they had a psych assessment. And what they found was anywhere between 20 to 47% of them have an underlying anxiety disorder, and a good portion of them had actual panic attacks as their cause. They also found that the parent of the children have underlying stomatization and other psychiatric symptoms as well. We know from what I shared with you that there is a red flag criteria. I am proud to be part of the team that had developed that criteria and had embedded within EMR. And we know that the majority of the children coming to cardiology with chest pain to our clinic will leave our office with a normal heart and don't have an underlying cardiac disease. Any other questions or cause or concerns or thoughts? Any questions?
Questions if there are please introduce yourself and use the mic.
Hi, I'm Jenna. I'm at White Oak Pediatrics. So I'm just curious. So I've been noticing over the last year, a lot of the sports physical forms we're getting are, I feel like previously it used to say, is there a history of sudden, cardiac death before the age of 50? And I've noticed lately it says 30. Is there a reason for that change in the age?
So the question was, when you do a sport clearance, the question is there any sudden death in a relative?
The sports form says, like, they ask the parent on the parent section. It asks, yeah.
Okay, I'm not really sure why the change happened. And, in general, like if we hear about a sudden death in someone less than 40, we will be nervous enough to say, let's look into this and see if there is any underlying condition.
How are we doing here, folks? Dr. Fox? Hmm? I'm trying to figure out how to advance this.
That's okay. We're talking from this morning.
Yeah. Oh, here we go. So, we're bringing back Dr. Fox to the podium to sort of engage you a bit in conversation, but I'm going to ask a question to actually our audience, just sort of. So one of the things I was struck by, part of what we are doing today is pausing, looking at historically all the drivers that sort of inform our practice habits the way we are, including, you know, we're busy, we're trying to work our way through busy schedules with lots of concerns or whatever. We have certain habits and behaviors about, oh, this kid's getting referred. But in the grand scheme of things, I think we are trying to sort of look at who we are and what we're doing and sort of be a little more thoughtful and intentional about managing appropriate concerns for a primary care medical home, as well as sort of figuring out how to partner best with our specialists and develop models for collaborative care that are shared not just with our primaries and our specialists, but also with the family. It's really a trio that we need to sort of get together. This is a case study in a couple of different things. What I think is helpful for our audience to hear is that this was a collaborative study between our primary care practitioners and our specialists, who were very intentional about looking at the way they've historically done things and actually using some knowledge and some training and some quality improvement to sort of change their practice behavior to better manage this concern and keeping things in the primary care medical home that make sense, as well as helping the kids who do need to get in cardiology more acutely, you know, get there. And I guess my question to the assembled audience is, how many of you would be willing to do some pilot work in this space with different specialists, just by show of hands? It's not real busy work, but it's work that just requires us to think a little bit differently about how we've always done things and how we might begin to sort of do things differently. So we got a couple hands coming up, Dr. Fox. What do you think?
So what Mark said, no, yeah. So from following up on this morning's conversation, that was great. Thank you so much for those presentations. So we definitely have a theme going, right? So folks are getting up here talking about common conditions, giving us some tips and best practices, some algorithms, and then us sort of brainstorming a bit to figure out how do we implement this in a way that actually leads to better outcomes for our kids. And so what I loved about, you know, what Ari and Ashraf just presented was, it was very practical, you know, small change, focus on a specific condition, somehow build it into your everyday workflow. My friends at CMPA have confessed that since they switched their EMR, it is no longer necessarily built into a template. So then, as Ashraf pointed out on the run chart, we do great while we're focused on the QI project. And then something goes slightly awry, like we switch EMRs or something. And then all of a sudden it's not built in. And so then it depends on the individual provider remembering to do all those steps. And that's where it all starts to fall apart, right? So just really trying to think through ways of how to standardize some of this work, right? And so part of the idea of these mini sessions was to have you all give us your thoughts and feedback. And so definitely we'll punt it back to you all like Mark just did. If you all have done work like this with other specialties, please get up, share. A couple of folks after this morning session did come up, and I won't put you on the spot, but I did ask you to come up to the mic and perhaps share what you had brought up. Some of it was specifically around how do we better disseminate information and how do I better get in touch with specialists and providers, and how friendly or not friendly it is to get in touch with different departments. And so I will just open up the mics and see if folks want to share some thoughts about what has worked well for them and what are maybe some challenges that they would like us as a network to sort of work with them on and problem solve. And one of my colleagues is taking notes.
Hello. So I think what's worked well for me is the book with email addresses of all the specialists and being able to email. Like the other day, I emailed a geneticist to see if a kid needed to come in for testing. They ended up looping in their scheduler and we we're able to get the kid a pretty quick appointment, which was very helpful. Unfortunately, that doesn't happen with every specialist. Some specialties will only tell us if we need to send the kid to the ER or not. And so it'd be nice for there to be kind of across all specialties guidance. But one thing that I found online was that Children's Hospital of Orange County has a whole referral guide online where they have every single specialty, and then under each specialty, they have every condition, how urgent it is they need to be seen, what labs you should do in the primary care office, what information they need when you refer a patient. So if like you're going to endocrine, you need the growth chart and these lab results and a bone age or whatever. And then they also have a referral sheet that you fill out with your concerns, attach all those documents, and they have like a list of all the things to attach on so that there's this packet that goes. And I think having something like that would help with communication as well.
Well, thank you. And if you share, please introduce yourself. That was Julie Berg.
Hi, just piggybacking on Julie's comment. My name is Florencia. I work at Einstein. And after residency, I did my residency here. I worked at CHOP, and they have a very robust clinical pathway program. I think a lot of us probably have used their pathways. They're open, public, but I found that it really kind of standardized at least how everyone was treating certain things and when to refer. They have an amazing one for otitis and constipation and chest pain. And so that might be something to think about. I know we have, at least when I was a resident here, we had pathways for Kawasaki, but maybe making them a little bit more outpatient would be helpful.
Agree, great.
Hey, Mike Martin. I'm a general pediatrician, work with Florencia. So yeah, I love all the algorithms, and I love a lot of the cooperation, the PHN, you know, and even in Virginia now with Trusted Doctors, there's a lot of integration going on, which is wonderful. The one gap I continue to see, and we all know, is like we have all of these psychologists and mental health providers. I am curious, like how much they have been asked to come and join in some fashion into working with us, because there are all these little islands, and I gotta believe that they need help with management, because I see a lot of them struggle with that piece anyways, that there's value in what we are doing in that regards too, even if they're doing self-pay, I mean, they still need help in some of that stuff. And we do have things we can align with, but also bringing them in and helping with communication and how we work, they work. I don't know, I just haven't seen that really move anywhere in terms of us working with smaller providers and bringing them into some kind of network as well.
Great idea. I know that there are other folks in the room who are spending some time and energy specifically trying to address how do we sort of better align or collaborate with our mental health, behavioral health colleagues. And I agree, especially when they're what I would call off the insurance grid, right? Interestingly, some of the other CINs or clinically integrated networks, that's what PHN is. So most hospital systems have a clinically integrated network, and a number of them are bringing in some mental health or behavioral health practices. And so there definitely are models for doing that. Some of those CINs are a little further along in their evolution. And so, and it does help to have payers on board that make it more inviting for them. So yes, and I think it's a great idea. Correct. No. So yes. So no, yeah. So the point is that we've seen models where we've integrated the behavioral health person into our own practices, but are there models for where those behavioral health practices actually stay working as their own behavioral health practice, but they become part of a network like ours? And that's actually what I'm alluding to. So some of the other CINs have done that, where they've brought in a group of psychologists who maintain their practice as a group of psychologists, but they become part of the wider network. And there's actually payer contracts that address and reimburse those practices for being part of the network as part of. And so yes, we have a lot to learn, and we can certainly try to sort of incorporate some of those ideas. Absolutely.
So my name is Marcella Daniel. I'm at Foxhall Pediatrics in Northwest DC. One thing that has absolutely helped is direct messaging, not kind of having to track down specialist notes and seeing if they've been faxed or trying to, call the offices and get them urgently for a patient following up regarding something. So our EHR did not have that initially, but once it was added, we saw that there was really excellent value in getting those, real-time notes. Something that only happened one time is that I had a patient who had new onset absence seizures, and Beth Wells Neurology set up a telehealth between myself, the family, and her to talk about medication options and treatment. And we kind of coded it as continuity of care. The family had a lot of questions, and it was really tremendous to have, that interaction to let them know, I know Dr. Wells knows me, I still have a face. But I don't know how practical that is. I don't know if that's a touchstone for, some of the more complex patients or, new diagnoses, kind of getting the family on board. But if there were a way to do more of it and have it make sense for the schedules and the billing, I think it would be really valuable.
That's fantastic. Thank you for sharing. I think we'll have one more.
Hi, I'm Jeannie Chang Pitter. I'm with Children's at Foggy Bottom, Capitol Hill. So having been part of Children's for quite some time, I guess I can say that there's pieces of the system and also of, I guess, the role that I could see maybe potentially PHN filling that could be particularly helpful. One thing is being within Children's, I am privy to some of the clinical protocols that are behind like a firewall, but not everyone in the communities has access to those. It can be difficult though still to find it, even though I'm within Children's. I also though find that I am still, even having been with Children's for over 15 years, learning about new specialty clinics, which are pretty amazing, like Mayhew Clinic with hematology and gyne, or like Vulvar Clinic with derm and gyne, and sorry, it's not just gyne, but the idea is that there's some great resources within Children's, incredible sort of collaborative care that's happening that would be wonderful for patients as well to see more than one specialist at a time, but primary care providers may not be aware of them or how to get them in there. And so if that's, I imagine if it's challenging for me within Children's, I can only imagine what it's like for community pediatricians. So could there be an app? Could PHN be the place? I mean, I think about the Constipation Action Plan and some of the successes like with the chest pain QI project, that many people still go to PHN's website for the Constipation Action Plan. And so potentially if all of these things were in one location, and that was the go-to for clinical algorithms, how to access care, advertising new sort of coordinated clinics, and then also potentially sort of knowing what is the best way to contact someone if you can't get somebody in. And so I feel badly for some of the specialists, some of who are in this room, who I tend to email a lot, because it's like, we'll find one person in a division and email them about our challenges or our patients or challenges with access, but that can't necessarily be the systemic solution.
Fantastic. Thank you very much. That's great. All right. And with that, actually I have one polling question. So the Constipation Action Plan has been around for a while, and it is the thing that most people go to our website to look for, which is interesting. It's the most, I guess, downloaded or touched or whatever word it is that people do traffic. How many people actually incorporated the Constipation Action Plan into their EMR? So at least one group. Okay. All right. Which highlights how maybe not easy it is to do that. So, okay, great. Thank you very much. Yes.
All right, folks, we're going to have one more short break for about 15 minutes. Then we have two more presentations teed up, and we'll still get you out of here at a decent hour traffic-wise. The last two presentations are on collaborative care for asthma and for autism. These are things we see a lot of in our practice. They're going to be really great presentations. So look to see you all back here shortly after 3:15. Thank you.